Welcome everyone. I'm Helen Makregiorgos. Before we begin the event officially, I would like to pay my respects to the traditional owners of the land on which I stand today, the Wurundjeri people of the Kulin Nations, and pay my respects to their elders past, present and emerging, and to community members here today. In particular to Auntie Di Kerr, who will be doing a welcome to country to begin the session shortly. Sovereignty was never ceded, and given we are discussing mental health, I would like to acknowledge that there is much we could learn from our First Nations communities' social and emotional wellbeing approach. I would also like to acknowledge people with lived experience of mental health issues and or the system who are present here today. On the screen, we're sharing quotes from consumers who've used IMHA. A few things to note regarding today's event. The session is being taped and will be posted on BLA YouTube. As it is a webinar, your microphones are muted and we encourage you to put your comments in the chat. We also ask you to put your questions to the panel in the Q&A section. Whilst we may not be able to answer all questions, the session is being taped and we will share these with the panel members so they have them. I would now like to introduce Auntie Di Kerr, Wurundjeri Elder, who has been working tirelessly for the last 25 years on social, health and wellbeing issues that affect Indigenous people. Her working career has included community work at Dandenong and District Aboriginal Cooperative, childcare, native title, link up, stolen generations, education and cultural awareness to the wider community. All of this has led to her current path of looking at ways to strengthen the social and emotional wellbeing of Aboriginal peoples. We are very honoured to have her here to welcome us to country. Over to you, Auntie Di. Sorry, Auntie Di, you're on mute still.
On mute. Can you hear me now?
Yes, we can.
It's a new learning thing for me, all this stuff. I'm really, really sorry.
No, that's all right. I think we're all learning with you, Auntie Di, so it's fine.
I honour my ancestors and my elders, and I pay homage to this sacred ground that we're all on, and for all the grounds that you're on. I wish to acknowledge all Aboriginal and Torres Strait Islander peoples and the First Nations peoples from across the waters, and I acknowledge you all and I pay my respects to your ancestors and families. And thank you for inviting me to welcome you all today. It's an honour, and I have been privileged to do a number for IMHA. I think I did your first welcome, and it's an honour that you've asked me to do this today. And yes, I have been working with emotional health and wellbeing, and especially at the moment, you know, we're all a little bit emotional and our wellbeing isn't very good. And at the moment, with this last little bit that we're locked down, and it's not very good for any of us at the moment. And I know that my health is not travelling very well, and my mental health has not been really good. And we've been trying to find ways to assist each other, and Facebook has been sort of really good for us. And we formed a little group called We Can Do This, and we get on there and we share things and talk about what we're doing. One lady does a cooking class for us. Another lady does takes us for a walk out the bush because she's allowed out. We have a lad called Mal Power who's up in the Torres Strait, and he gets on and talks to us for a little while, and his cousin does Dreamtime stories from up there. So that's been helping us get through, and I think last count we had something like 1,500 likes, and so anybody can join if they look it up. But we all need each other. We really do. And it's not just during this, it's after as well. And a lot of people are scared of people with issues with wellbeing and mental health. And, you know, it's important to realise that it's not about being scared. It's about acceptance and about getting rid of that stigma. And I know that my children have been brought up to respect people and respect people with problems, you know, and a lot of people haven't been brought up that way, and they find it very difficult to communicate with people that have hard communication skills and that are going through a special a moment and a problem at that moment and got issues. But if we can stick together and look after each other and be a community again in caring for our neighbours and caring for each other, caring for the person on the street, we can get through this. And sometimes I find that ceremony is very important, and I go into a lot of psych units and the hospitals, Thomas Embling and other places like that, and do smoking ceremonies. I find that helps and calms people. Ceremony seems to calm a lot of people, and that's a physical thing, and it seems to be able to help. And you know, smoking ceremony is 60,000 years old, and when people can place a gum leaf in the fire and be connected to that fire and connected to country, if you have a connection and a well-being connection, your heart's a lot stronger and you feel safer. And I think it's very important that people feel safe and feel connected. So when you're talking about things that can assist people, please think about having ceremonies. And it's not just for Indigenous people, it's for all peoples. It's very important. And lots of different peoples have lots of different ceremonies. And sometimes people forget that there are different ceremonies to be had. And we need to share all of those. And I know I get privileged to go to different faith ceremonies once a year, and they're empowering, you know, to be able to sit there and listen and share different faiths. So even if people do that, that helps and gives you a goal and enlightens you and helps you feel safe. The whole thing is about feeling safe. So I hope that you enjoy your meeting, and I hope that you get some really good outcomes and be honest with each other and share. So can I just say, may Bunjil, my Creator, surround you all and give you strength and resilience. And on behalf of my elders, I say, Woman Jika, Wurundjeri Balik, Yemen Gundibik. That means welcome to Wurundjeri country. And all of those that aren't on Wurundjeri country, I can't welcome you to that country, but I can acknowledge that country and if you help you feel safe on that country. So Nungodjan, thank you. Thank you for having me, and have a good day.
Thank you, Auntie Di. My name's Louise Glanville. I'm the CEO of Victoria Legal Aid, but just listening to you speak there, I really felt the sense of importance that you're talking to us about, of connection, of inclusion, the importance of ceremony itself, and of the way in which that makes people feel safe. And I think your words are very wise, unsurprisingly, very valuable for us, particularly at this time of COVID, but more generally. And you have delivered a very potent welcome to us. And so thank you for spending the time to do that. And I hope you can stay with us, but if not...
I have to go to another meeting. I'm really sorry. I'd love to stay.
No,
I'm so sorry.
Fine. That's fine. We just so much value having had you here and to give us that welcome. It's a real gift and a treasure.
And congratulations on your 5th anniversary.
Yes.
I remember your first meeting. Amazing. Good on you.
Thank you so much, Auntie Di. Bye-bye.
Okay. Bye-bye.
And I too would like to start by acknowledging the traditional owners of the lands on which we're meeting. For me, that's in Wathaurong country down near Geelong, and to pay my respects to elders past, present and emerging, and to note that their lands were never ceded. I'd also like to acknowledge all those who've joined us with lived experience of mental health issues, and thoroughly welcome you to this 5-year IMHA event. It's terrific to have everybody here. I'd also like to make mention of clinical directors and operational directors that are attending from some of the designated mental health services across Victoria, to Anna Lowe, the Chief Mental Health Nurse, Jan Dundon, the Mental Health Tribunal CEO, Matthew Carroll, the President of the Mental Health Tribunal, Treasure Jennings, MHCC and Disability Commissioner, and Marie Piu, the CEO of Tandem, which is of course a peak mental health carer body. Thank you very, very much to all of you for attending and joining with us in this very, very special and really uplifting celebration of 5 years of IMHA. Many of you would know that this event's being held in Mental Health Week, and that's appropriate because IMHA was set up after the passage of the Victorian 2014 Mental Health Act to safeguard the rights of people receiving and at risk of having compulsory mental health treatment. When I think of IMHA, and I've had the pleasure and the privilege over the last couple of years as CEO of Victoria Legal Aid, of spending time understanding this very important service that we provide. But there are several things that I think of. Firstly, I think of people better understanding their rights and having a say in their treatment. And so for me, this is a piece of empowerment that is vital for us as all Victorians who may experience mental health issues ourselves or come into contact with those that do, to really hold closely and dearly this concept of ensuring that people can understand their rights and have a say in what their treatment might look like. When I think of IMHA, I also think of the connection between non-legal advocacy and legal advocacy. And I think this is really very, very important in the context of ensuring that we deal with the whole of people's lives and not just a legal problem as such. And so for VLA, we have been on this journey for some time now to make this connection between non-legal advocacy and legal advocacy. And I do love the way in which IMHA gives real life to this as a possibility. And I watch with great interest the successes and the stories that come from the work that IMHA does. And to me, this embodies this sense of combining non-legal and legal advocacy certainly to assist users with our services. I think the third point I'd really probably highlight as the most important in my learning from IMHA is putting consumer leadership and engagement very much at the centre of what we're doing here. And in fact, we can't really, I think, design services properly or understand the experiences of people thoroughly unless we actually take this very primary step, which is to put consumer leadership and experience at the very centre of what we do all the time. If I look back over the last 5 years, and I'll have to read these statistics because they're big numbers, but I can see that we have had 41,513 advocacy and coaching sessions, 79,701 information and referral services. And this has been to thousands of consumers or users of our services, as I'd like to call people. I also believe that we've assisted in building capacity in mental health services, working alongside health professionals and others to really think about how our mental health services can actually be improved and enhanced continuously. And we would all be very cognizant of the fact that in several months, the Mental Health Royal Commission will be handing down its final report. I think this has been a terrific initiative by the government to set up the Royal Commission, and we look forward to hearing from Penny Armitage and her fellow commissioners in terms of what are the real ways forward for the mental health system in Victoria. And we know there are some challenges ahead. From Legal Aid's perspective and from IMHA's perspective, we've been particularly keen for there to be several recommendations that might relate to IMHA being an opt-out service for all consumers rather than something which is opt-in or in fact that someone might happen to come across. We'd like it to be available for everyone and an opt-out service in that way. We also really think that the future of the mental health system in Victoria should be heavily dependent and in fact imbued thoroughly with consumer leadership and engagement, as I've talked about previously. We think this is absolutely core to us being able to address and correct some of the issues and experiences that people currently have in our mental health system. So we're vitally interested in that recommendation as well that we've made and what might happen to that. So thank you again for all your attendance. We're looking forward to a really exciting panel discussion this morning. And I'd now like to hand over to Helen Makregiorgos to take us into that next session. Thank you.
Thank you, Louise, for that warm opening. And I think also highlighting that we are a significant moment in terms of mental health with the Royal Commission preparing to hand down in February, and hopefully for many people looking at a system that is centred around consumer leadership and rights and recovery. So we're going to move on to our panel discussion now, and we're very fortunate to have 3 panel members with us today. The panel members will speak for 3 to 5 minutes each about the mental health system and their vision for a system that has rights, recovery and consumer leadership at its centre. I will put questions to them at the end of them talking to us about their thoughts on and vision around the system. The questions, you can put them in the Q&A, as I said earlier on, and we'll be picking questions to ask the panel members. We might not get through all of them, as I said before, but we will put them all to the panel because we are taping the session, so they will have them after the session. First, I'd like to introduce Cath Roper, who was also part of launching IMHA 5 years ago and one of the many consumer leaders who advocated for an independent advocacy service as part of the changes when the Mental Health Act was introduced in 2014. Cath holds a pioneering consumer academic role at the Centre for Psychiatric Nursing, using perspectives arising from lived experience of mental health services. Cath develops and co-delivers training across specialists, mental health service settings, and coordinates, teaches, and assesses a core consumer perspective subject in the postgraduate diploma in nursing mental health. Secondly, I'm going to introduce Dr. Chris Maylea, and you'll be able to see our panel members appear up on your screen. Dr. Chris Maylea is a mental health social worker, lawyer and academic at the RMIT University Social and Global Studies Centre. He's also the chair of the Victorian Mental Illness Awareness Council, so VMIAC. His research focus is on the intersections of health, welfare and law, particularly mental health. He has published and presented extensively on non-legal advocacy in involuntary mental health settings, and 2017 led the evaluation of IMHA that was published in 2019, and he will talk a bit about that. Dr. Maylea is also an author of Social Work and the Law, published in 2020. Finally, we're welcoming Dr. Sudeep Saraf. Dr. Saraf is a psychiatrist and program director of Alfred Mental Health and Addiction. He's also a psychiatric member of the Mental Health Tribunal and medical panels. Apart from his professional experience, he also brings the perspective of being a person from a non-English speaking background, a migrant into this country, and an international medical graduate working in the public healthcare system. Sudeep was also a member of VLA's reference group that informed the establishment of IMHA over 5 years ago. So I think we'll hand over to Cath so she can start us off.
Sorry, I didn't realise that I can actually have control of the mute button. It's great. Thanks so much, Helen. I want to also start by acknowledging the traditional owners of the land on which I'm speaking, which is the Wurundjeri people of the Kulin Nation, and I want to pay my respects to elders past, present and emerging, and say that sovereignty has never been ceded. And I also want to thank Auntie Di for her words, and hearing those words made my heart feel so much stronger. I really want to thank Helen, you for inviting me to be on this panel to celebrate IMHA's 5th birthday. I think I slightly missed the brief. I'm less on vision and more on wanting to say how great IMHA is to start with. But I guess encapsulating my vision in a very sort of couple of words, it would be to absolutely emphasise consumer leadership across everything that happens in the reforms that we're going to see happen across all service delivery. This is the only way that we're going to see change that is meaningful and lasting and will sustain and will be human rights focused. So I also remember the launch 5 years ago, and it was very exciting. At last, consumers would have access to advocacy. This is such a big deal. There'd be someone who wouldn't judge you, who would actually listen to what you wanted, who'd help you to know and act on your rights. And everything I wish I'd had in the 13 years of involuntary admissions that I had and the forced treatments that I'd known, I wish that I'd had an advocate then. In these 5 years, IMHA has lived up to and exceeded its promise of being a saviour for so many people who need someone on their side when they're an involuntary inpatient. Last year's evaluation conducted by RMIT sets out many of those achievements that we're celebrating today. But rather than comment on those, I want to just single out a couple of strands of the organisation that I think have really made IMHA outstanding as a resource to consumers in Victoria and a real beacon of light. These strands were there from the very beginning, and they're built into the DNA of IMHA and its leadership and all of its structures. So the first is this human rights-based culture that informs the heart and soul of IMHA from the top to the bottom. This is so rare. And I'd like to see IMHA be used as an exemplar for how organisational systems and processes and practices their decision-making can actually be human rights informed. How did that culture get created? How is it sustained? How does it manage to inform the relational approach that IMHA actually has with the mental health services? And how is it successfully produced and reproduced in the work that all the advocates and staff of the organisation do? The second is the role that consumer leadership and consumer expertise play within the organisation. From its establishment, IMHA has incorporated a senior consumer consultant position, and that ensures that the organisation can maximise the benefit of consumer perspective and everything that it brings. The Speaking from Experience Consumer Expert Group also provides advice to IMHA about its approach and decisions, and it's involved in education and the training of staff. This group helps to ensure that mental health consumers can shape IMHA's direction so that the service is responsive to the expertise and needs of consumers. And I guess I'm reading between the lines, I imagine IMHA puts an awful lot of emphasis on practice supports, and navigating the ethically troubling waters of mental health services requires all kinds of savvy and relational skill. Being there with a consumer, holding a line, bearing witness and standing with them is not easy work in such a context. You need a sense that your organisation is holding you. IMHA organisational leadership and management models the supportive, reflective approach to practice that we would wish mental health services would adopt. So interestingly, the evaluation report found that even in situations where consumers' advocacy goals weren't met, they were still incredibly happy with the service received from IMHA, and I think this says everything. But what is going on in our approach to people in distress that means dignity and respect are noteworthy? So it shouldn't be like that. In physical health, you can refuse treatment. In mental health, it's special and you can't. It would be trespass and battery if you did this normally. We get special laws so that when people, if they don't want treatments on offer, they can be administered by force. So if you're curious about or in doubt about how harrowing people's experiences can be and how great is the need for IMHA's services, just read Your Story, Your Say, the report by Victorian the Victorian Legal Aid for the Royal Commission into Victoria's mental health system. It makes really important reading. So until we have social and community responses to crises, distress and duress that are non-coercive, IMHA will be needed. As recommended in the evaluation, and as Louise said, it needs to be sufficiently resourced so it can grow to provide an opt-out service to all involuntary consumers. This is something I think we really need, consumer leadership and an opt-out service just to start with, so that it meets the needs of all involuntary consumers and people in the community as well, whose rights are being infringed, not just inpatients. And so that it also is there as a service for people who are at risk of becoming involuntary. So people realise they're not alone, someone's in their corner, someone is listening, and they're not basing their interactions with you on judgments about mental illness, and so that people realise there is someone who will help them understand what options are available to them. IMHA will be needed. Happy birthday to IMHA. And thanks again, Helen.
Thank you so much, Cath. It was, just lovely hearing you speak again, just like it was at the first when we launched the service, but really just, I think you're summarising what you've seen from IMHA, and I agree, and I think all the staff would agree that consumer leadership and embedding it within the service has been critical to what we saw in the evaluation, but also the generosity of consumers who are often distressed, who contact us constantly to give us positive feedback and to set us like quotes like the ones you read at the beginning, that really, I suppose, encapsulate for us the important role the advocates play day in, day out in the services, listening to people's stories, believing people's stories, and being there just for them in that part of their, period of their journey through the mental health system. So thank you very much, Cath, and I'm sure we'll have questions from the audience for you as well. So I might hand over now to Chris, who's going to talk to us briefly as well.
Thanks, Helen. Is my audio okay?
Yes, it is.
Great. Thanks, Helen. I'm on Wurundjeri country too, which is Witchetty Grub country. So thanks, Auntie Di, for that very generous welcome. I'm very pleased to be here, although in a way I'm also not really pleased to be here. I'll explain why in a minute. But first, let me say happy birthday to IMHA. Congratulations to VLA, the IMHA staff, and particularly Helen. I have my own 5-year-old who's currently playing with Lego in the next room. So I know how proud you must be feeling right now, having made it through the sleepless first year, the terrible twos and the delightful toddler years. It must feel amazing to be here for IMHA's 5th birthday. Unlike most parents, I hope you'll be spared the awkward teenage years, though, because as happy as I am to wish IMHA a happy 5th birthday, I really hope I'm not here to wish it a happy 10th, 15th or 20th birthday. And let me explain why. I'm pleased to be here because IMHA is, in my professional opinion, one of the very few functioning parts of the mental health system. In our evaluation, we spoke to over 100 consumers. Of those 109 consumers, none of them had anything negative to say about IMHA, not once. It's 109, nothing we spoke to had nothing negative to say. When pressed, and we did press them, they said that perhaps the one thing they didn't like about IMHA might be that there wasn't enough IMHA to go around, or that they wish they had IMHA earlier, or that they needed better posters so that people could access IMHA more easily, those sorts of things. I did every one of these interviews and focus groups in inpatient units and in the community, searching for someone to say something bad about IMHA, and nobody would. No consumers would say anything bad about IMHA. When we tried to work out why people loved IMHA so much, it wasn't hard. IMHA does the basics of listening and believing, of compassionate relational interactions that are just so often missing in the mental health system. That's why people who used IMHA loved it, and people who didn't have it wish they did. And that's why I'm happy to be here as IMHA turns 5. I'm also pleased to be here because as a social work educator, when my students ask me how they can do human rights-based social work in mental health settings, I can point to IMHA and say, that's how you do it. That's how you do human rights-based social work in mental health. IMHA isn't just social work services, but it's a model of social work advocacy. IMHA is a service which does those social work things of relationship-based advocacy, of recovery-oriented practice, and it does them well. It shows social work as a way of working in co-design and development that social work badly needs right now. Also, as the chair of VMIAC, when I'm looking for allies to support consumer leadership, I can reach out to IMHA, and I know we'll find someone we can work with on strategic advocacy. I know that the shared human rights basis means we can work quite separately and still really be working together. The VMIAC is very supportive of IMHA, and I might take this opportunity to say happy birthday to IMHA on behalf of VMIAC too. But I'm not pleased to be here because the very fact that IMHA exists and that people want and need it so badly is a ringing indictment on our mental health system. If our system functioned properly, we wouldn't need IMHA. I mean, there might be a small role for assistance with supported decision-making where independent advocates would still be useful, but in a mental health system that really truly listened to people and respected their rights, where consumer leadership was the norm and not the exception, where recovery was a journey of the heart, not of compliance and enforcement, the IMHA intake line would hardly ever ring. IMHA is part of the journey of this, utopian vision of a mental health system. It can show mental health services how to engage respectfully and compassionately with people in distress. And it can share its expertise in supported decision-making and rights-based approaches, and it does do that. But it needs services to let it in and to accept that change is not only possible, but essential. The single biggest barrier to IMHA getting to more people is the resistance of services to work openly and honestly with IMHA. When services do that, everybody benefits. The services, the people who use the services, everybody. As a former mental health services manager, I understand the difficulty in being advocated at, of being told that your best isn't good enough, that you're actually harming the people you're trying to help. It's hard. The painful process of shifting culture is excruciating. The process of giving out power can be terrifying, but it must be done, and IMHA can show us how to do it. Until this process is complete, everybody needs access to IMHA. This requires an opt-out system where every person is eligible. Every person who is eligible is automatically referred to IMHA, and then funding to match the demand, including in crisis situations and after hours. With the system as it currently is, everyone is entitled to an advocate. This would also help with systemic reform, as IMHA both highlights areas that require reform and role models human rights-based practice. So when it's done, we'll know it is done because we no longer need IMHA. This should be our goal, a mental health system so good that we no longer need IMHA. First, though, we need to let IMHA show us how to fix it. So happy birthday, IMHA. I hope it's your last, although we might need you to stick around for some time yet.
Thank you, Chris. And I think just highlighting some of the things Chris said. Chris and I did have quite a number of conversations in the evaluation around the fact that he couldn't find any consumers to say anything bad about us, and he really kept saying to me, "Are you sure you didn't pick those people that I was speaking to?" That was, obviously de-identified, and I didn't know who he was speaking to. But I think it was really struck me, and I think for the team, it's really important, particularly the point that I think Cath might have also made, that for consumers, it often isn't about outcomes. Even I think for the advocates, it can be really challenging to carry that when you can't see any change happening for consumers. But it was more about the experience of actually having someone there with them. It was more about somebody who, in a powerful system for them, was there just for them and was able to listen to them, believe them, and also support them to, I suppose, at least express what it was they were wanting to see happen. And I think your vision, Chris, of a system where we don't need IMHAs, I'm sure that IMHA would, also agree with that, a system that doesn't need it means that, the mental health system is doing that in and of itself, and consumer leadership is at its centre. But yes, at the moment, we're very happy to still be here providing services to consumers. So I will now hand over to Sudeep and give him a minute to also speak to us.
Thanks, Helen, and let me begin by acknowledging the Boonwurrung people of the Kulin Nation, the lands on which I am based at the present time, and pay my respects to elders past, present, and emerging. And happy birthday, IMHA. I was there 5 years ago. I remember meeting Cath, Indigo, and several others, Wanda, when discussions were taking place. And as I was listening to both Cath and Chris, in many ways, at that time, what I thought of what IMHA would be and how they would evolve is quite different to how you have. And this obviously reflects, I think, what Chris was just referring to in terms of how ingrained we are in the system and how we are shaped by the system. And it takes time for us to be open to ideas and expose ourselves to a different way of thinking. But just reflecting broadly on the health system as such, not just the mental health system, the health system as such, what we're seeing, I think, is a shift, and it's the right shift, of people having more autonomy and self-determination. And Cath just mentioned about people going into non-mental health part of the health system, as in for medical conditions, and having the choice and autonomy. I would like to believe that's true, but I don't think we are there yet in terms of having the true choice and true autonomy in any part of the health system to the degree that we would want it to be. And of course, in the mental health system, perhaps we are a lot more challenged. And I think from a healthcare professional, it's something that people are trying to get their head around. It's a culture change that, as Chris was referring to a little earlier, we need to be more comfortable in allowing other people to hold a little bit of power and a little bit of control on how different medical decisions are made and taken. And I think this is a shift from effectively centuries of thinking. We had the best interest principle forever, and we have moved from that best interest principle to a place where we want to go, where a person who receives the service is the owner of the decision rather than the person who's providing the service. And this will be a monumental shift, and this will take time. And look, I agree with Chris that we would want to be in a situation where IMHA doesn't have to celebrate the 10th and the 15th and the 20th birthday. But the reality is we are trying to change how people have practiced from ever since, if you like, medical profession existed. So it's a big shift. And we'll get there at some stage. I don't know how long it will take, but I think eventually we'll get there. I had a few other things I'd written down, but I just thought I'll share a personal experience I've had with an IMHA advocate who I just see is among one of the attendees, which it's all positive. So, I had a meeting booked in with a consumer, and the IMHA advocate came along. This is about probably 2 or 3 years ago now. And essentially the person was somebody who had been on CTO for a period of time. And IMHA was coming to advocate on behalf of the person. The person obviously did not believe that they had to be on a CTO. And what was good about that, and my own learning and reflection from that, and which I've sort of carried over in other interactions I've had with consumers over time, was a suggestion that perhaps we should give the consumer a roadmap, a written roadmap of what needs to happen for that person to come off the compulsory order. And we did that in the subsequent meetings. And it was great because it gave the consumer a sense of agency and control. And they were part of this whole process of how, a decision could be made and shaped, which otherwise was effectively a stalemate where they would come to the meeting, I would say something, they would say something, and, they would walk out dissatisfied. And I think it also gave the consumer a lot of hope for how things could be different for him going forward, with some of the things that we had agreed to work on. Now, this is something I have subsequently used on a number of occasions. It's shaped my thinking substantially over the time that I have been seeing people. I think, in a sense, from a healthcare professional, it comes down to us taking some time to reflect on our practice and having these conversations with advocacy organizations like IMHA. I've had with VMIAC, when I've had phone calls and I've had phone conferences with advocates, supporting consumers. But all these things, I think, will go towards shaping the system the way we want it to be going forward, because change takes time. It is difficult. It is also anxiety provoking. And the anxiety comes from a number of sources. It also comes from, whereas on one end, we are talking about a rights-based system, which is where we want to go. On the other end, the regulatory bodies don't necessarily see it in that sort of way. So when things don't work out, a lot of expectations are placed on services, which really don't solve a problem or actually don't improve the system, but constrict us even further in terms of how we can progress in this direction. But look, like I said, we will get there. We just need to keep soldiering on, and happy birthday again. I'll probably stop there for now.
Thank you very much, Sudeep. And I think to say as well, thank you for your support. You being involved in the reference group was really obviously important, but also your ongoing support, having been at the Alfred and now in the program manager's role as well. I think what you highlighted and what maybe others touched upon too, just the culture change, and that does take time, and they're talking about a very big cultural shift from where health and particularly mental health have been, and the importance, I suppose, moving from that best interest principle, which is obviously what IMHA is dealing with every day in terms of in mental health services, and moving towards one where people, do make their own decisions, but also supported to do that, as IMHA can do if that's what they need. Obviously, people make autonomous decisions, but if they need support, they get that support. And it's nice to also hear the story of you having contact with an IMHA advocate and what that looked like for the consumer, but also how it affected you thinking from then on. So I think now we'll move to questions we've had from the audience for the panel members. So I'm going to read them out. So advocacy is a clear example of a systemic change that needs to happen for better mental health outcomes. I'm interested to hear more about the resistance of services to IMHA and advocacy with and for consumers, and where progress has been made. So I don't know whether people who would like to respond from our panel. Chris?
Yeah, I think that was a point that I made, so I'm happy to elaborate on that. I think one of the things that kept coming up in the evaluation was that some services were really keen to engage with IMHA advocates and to bring them in, and actually to some extent to try and outsource some of their excess work to IMHA, because the number of psychiatrists had said to us, oh, I love working with IMHA. They can sit down with my patient, as that, is the terminology they would use. We'd sit down with my patient and spend an hour with them. I can only spend 15 minutes with them a week. So, this is great having someone to do the listening for me and translate it. So there were those services that really engaged with IMHA, and there were those that really didn't, and there were those that kind of saw IMHA as a problem, an extra problem to deal with or something. And I think my reflection was then, and continues to be, that actually the main reason we need an opt-out system is because the services that are doing the majority of the referring, and the services that are really open to IMHA and answering the phone when IMHA calls, are not the ones that most need IMHA in there as advocating on behalf of people in those services. So I think that's key. I think one of the things that I began to understand, and I kind of referred to in my little bit at the beginning, was that as a mental health professional or clinician, or however you want to frame it, there's a sense that you're the advocate, and being told that you're the problem and that you need to be advocated at completely undermines your identity, and you see this really kind of visceral. The people that we that were most supportive of IMHA, who were clinicians and mental health professionals, most of them viewed IMHA as allies to advocate at somebody else. Very few of them thought, yes, I need to be advocated at. Very few of them thought, I need someone to keep me on track. So that's really interesting that there's very much an idea of self-protection and a professional identity wrapped up in this, and that's really hard to change culturally.
Thanks, Chris. I wonder, Sudeep, do you have any reflections on this?
Yeah, look, some of which I think Chris has already covered in his response. When the Mental Health Act the new Mental Health Act, 2014 one, was being implemented, there was a fair bit of anxiety because there was changes that were coming into force, such as the tribunal having greater oversight of ECT, and which is how it should be, I would think, that the tribunal was making the orders as opposed to sort of ratifying it in a sense, if you like, which the treating psychiatrist made. And then came IMHA. So there was a fair bit of angst and confusion as to what the new act would mean. And then there was IMHA, which was coming and representing clients and advocating for them. So I think Chris is right in that services where the leadership has been supportive of inviting IMHA and being, to some extent, open to being challenged, as uncomfortable as it is, are the services where the resistance over time disappears or reduces. I wouldn't say disappears is the thing. It takes a lot more for it. I think it'll take a lot more for it to disappear. So it has been, I mean, I've been around the table when IMHA, we said, IMHA is going to come and provide an update or an education. And you hear different sort of voices around the table from people saying, well, they don't understand what we're doing. They don't understand the complexity. But what you also see is that was a discussion in 2015, 16. You don't see the same sort of discussion now in 2019, 20. I mean, we don't sit around the table anymore, clearly. We do all Zoom meetings. But you see that change coming slowly. And I think people, I think it's there in the report, as I was reading it yesterday, services did not understand what IMHA was meant to be doing or how they saw their role. So, in some ways, everyone wants to solve a problem one way or the other. So the advocacy to, let's say, go to NDIS, for example, or go to some other services, that sat very comfortably when IMHA and the services were on the same page. When it was, well, I don't agree with what you're doing, and if that's what the consumer said, that was more challenging, and that's to be expected in some ways. But I think when that happens, as has happened, I think with you, Helen, emailing me, or if it's the inpatient Fiona, who's also on the line, or others, and then sort of saying, well, this is what we are seeing in your service, what are you going to do about it? And then it is for us to have that conversation. So this will improve and change with ongoing dialogue that we'll have with a number of people, and we'll get there eventually, I would think.
Thank you, Sudeep. I don't know if Cath, did you want to say anything to this particular question? Or...
Oh, look, I think, yeah, I mean, I think for me, it does go back to things like people's capacity, when that's how we think about people, and we are rooted in a medical approach. I think that the autonomy, wherever that's the case, autonomy is, yeah, I think the best interest links in with this idea of mental capacity and human rights. So I think I want to look forward to a kind of a situation. I think culture will be hard to move. And I'm really struck, actually, I'm still sitting here thinking, Chris, about what you were saying about people who believe that they're the advocate. And so then to be sort of like, well, no, this is actually the impact of the legislative frame that means that people's will is being interfered with over and over. And so maybe that's the common enemy, if you like, and maybe, it's not necessarily the bad apple. We've got the culture in services that comes when you've got mental health legislation. There's no other way. You've got culture that you've got a legislation that actually takes away people's human rights. And so it's not an accident. It's not a bad culture thing. It's actually there's no other, it's what happens when you've got law. It's a special law. I don't know if that made sense, but...
Yeah, it does, Cath. I think what I'm hearing you say is that obviously because we have the legislative framework, which actually sets up the culture.
Yeah.
Yeah.
Well, yeah.
And how people are seen because someone else is making decisions for them.
Yeah, I think unless we don't have mental health legislation and we do have the services that people really need at the time that they need it, that's the same future that I guess Chris was referring to. We are going to have, it's not a question of bad culture, it is a natural result of having separate laws.
Thank you for that. I think just in terms of that question as well, and just to something Sudeep said, just a reflection from IMHA's perspective would be that things have changed in terms of engagement with us by mental health services. I do think that has shifted and looks quite different to what it did the first day that I started in the role compared to now with services. There is much more openness. And I think, to also say that there is, issues of capacity within the system, and we are running support decision making. And I believe the Centre for Psychiatric Nursing also does as well, a one-day session, but all the designated mental health services were open to us doing that for all of them. And we have, some of them have made it mandatory now. So I do think there has been quite a shift around the engagement with IMHA. I suppose it goes to that question. So I've got some other questions as well. I'm just scrolling through. There was a question about whether there's other IMHA services across Australia, which we could quickly respond to. Chris, do you want to respond to this, given you did look at this as part of the evaluation in terms of whether there is other IMHAs or similar services in other states?
Yes, thanks, Helen. Sorry, I just had to let my dog out. Yes, probably the closest thing is in Western Australia, where they have a mental health advocacy service, which is operates on similar principles, but I think in practice is quite different. In other states, the gap that is left by not having an IMHA is either filled by generic disability advocacy services, or sometimes mental health lawyers will step into those kinds of discussions. But no, essentially, other than Western Australia, which is because of the geographical issues in Western Australia mainly, quite a different service, Victoria is it.
Thanks, Chris. We've got a couple of other questions. One's, can IMHA really make real change as directed by patients, consumers, or is it a toothless tiger without powers to enforce? Would anyone like to have a go at that one in terms of, probably all got particular thoughts on that? Chris, do you want to have a go first? I might then ask Sudeep, being in a clinical service, what his views are.
Yeah, I think toothless tiger is the wrong expression. For example, in Western Australia, there are more statutory rights which we've recommended be adopted in Victoria as well. I don't think you could say that in Western Australia they fixed the mental health system over there just by having those statutory rights. So I think certainly I would like to see, I think more than anything else, it saves time that you don't have to wait. You can just turn up and say, the person has given me their consent to review their file. Please provide me with a copy. If there's a statutory right for the IMHA to do that, then that just happens without a fuss every time. Whereas now you've got to renegotiate with every single service every time you want to do something like that. You get a new nurse unit manager and they won't do it, and so you've got to wait till the next day or whatever. So I think it streamlines processes. I don't think it's the be all and end all. I think on a separate issue, it shouldn't really be IMHA that's getting extra powers other than the powers it needs to do its own work. It's consumers who need to be given those powers. So, for example, we've recommended in the evaluation that IMHA could do more work around, if it had more resources, could do more work around advanced statements. Now, if we had an advanced statements regime like the ACT does, then you could have advanced statements that were more binding, that had to be overturned by a tribunal, for example. And IMHA could play a role in making sure that those advanced statements that were actually binding were useful. So I think it's part of the reform process that's required. But what's really interesting, sorry to go on, but what's really interesting is that without those powers, IMHA has had to have this really relational approach, and that's worked really well. And so I think there's something to be said for actually not having those powers, because IMHA's had to put so much work into working with services to develop services and the relationship, both at a strategic level, but also every single advocate has to kind of get permission to be there all the time. I don't think that's great in itself, but it has resulted in this very productive model.
Thanks, Chris. Sorry, Cath. Oh, sorry, Cath. Were you going to answer before the question? Did you want to say something in terms of the question?
No, just I was listening fascinatedly, but I just at the end there, I was thinking, it does make another argument for really good and well-resourced legal advocacy as well, which is the tooth tiger.
Thank you, Cath. Sudeep, did you have anything you'd like to say in terms of that question?
Look, I think the broadly speaking, there are two ways of doing things. You bring laws, or you try and engage the people and help shift the way people, the way services are provided, or people who are working in the service. And I suspect you need both of them. So you need the powers to actually force people to say, well, you can't just be doing things in that particular way, but you got to, think of other ways of doing things. And I think somewhere IMHA and some of the changes that have come about in the last little while are sitting in that space where there are legal powers, if you like, to have access, perhaps, more access to their notes. And, some of this will be legal and some of it will be the way community is thinking at this point in time, and that forces the health services to change. So in many, particularly in Canada and US, where they have implemented their electronic medical records, 5-6 years prior to, where Australia is, they are looking at sharing information with consumers in real time. So, for example, in some hospital in Canada, the consumer and the doctor sees the blood results at the same time. Now, this is not mental health, this is physical health. That would, now you can't even get your own blood test results. You need to request somebody to print it out for you. And I think all these things, when you actually start, making information available to people, providing them that information, their own health records, for starters, all that helps. It also makes people think how they write things in the records, for example. So now that's not in legislation anywhere, but a technological change is bringing a behavioral change in people and how they react to things. So I think it's a combination of things. You have the laws, you have leadership, you have emphasis on changing the way we do things, or we can call it culture change. And that's how things, I think, over time shift.
Thank you, Sudeep. And I think I just want to make a note too, just from what IMHA hears a lot about, which is the notes which you briefly touched upon, the significance of that and how impactful that can be, that consumers don't have an opportunity really to see their notes without it going through a process, but also that often they do find it very distressing that things are written they don't necessarily have an opportunity to comment on or have input into. And that can be really disempowering for people and impactful as well. I'm just having a look because the time's, it's 5 to 12. I'm just looking at the questions to see if there's any question we could probably quickly take before I hand back to Louise, who's going to close the session for us. So I'll have a go at this one. We'll see if we can keep it brief. We have higher rates of CTOs in Victoria. There is a focus on reducing restrictive interventions in inpatient settings, but relative silence on the matter of CTOs. Does IMHA have an appetite to advocate for CTO reduction across Victoria? Oh, that sounds like it's directed at IMHA. Well, we clearly do have an appetite to advocate for that, and we do advocate for that, and we do see people in the community. I think Chris can talk a bit to the evaluation on this, but we are aware that we see a lower number of people in the community than we do in inpatient settings, and yes, the way we were set up was focused on inpatient units. Of course, we provide services to people in the community, but they are much harder to reach often and can be an invisible population for many people. But we're very mindful that that is a big issue, and that if we had an opt-out, that would also address that particular issue for us. But yes, I think it is important for us to be talking about CTO reductions in the community as well. I don't know if Chris or Cath.
Yeah, I think the answer to this is an opt-out system. If everybody who gets put on an order is referred to IMHA, we don't have a problem with trying to find people in the community. It was a really big problem actually for us in the evaluation to find people in the community, even when we had their contact details from IMHA. People just aren't interested in engaging with services in the way that they are when they're in an inpatient. They want to get on with their lives and leave the experience behind them. So yeah, I don't think an opt-out system is the entire answer to that, but it's a big part of it. And certainly effective IMHA advocacy really does reduce CTO use. We definitely saw that. So yeah, I think we calculated that it costs IMHA in terms of resources, in terms of funding, you can see about 8 to 10 people in a day in an inpatient unit, whereas it might take you all day to see one person in the community, particularly in a regional area. So it's much more effective to do that inpatient stuff. So opt out and more resourcing. Yeah.
Thanks, Chris. And I have to say, I think too, because of COVID, there has been an increase in, I suppose, of use of other technologies, and we have found that has actually improved access, at least in inpatient units, to us from regional areas where we could only previously get out once a month, and now we can see people weekly, really, but not necessarily in the community, where I think, yeah, there is still a lot of work to do. Cath, Sudeep, did you want to say anything to this particular point before we wrap up?
Maybe just to ask Chris, what he thinks the other, apart from opt-out advocacy might be. Is that putting you on the spot?
Yeah, no, I mean, I just don't have time to launch into another hour of what we need to do to fix community mental health services.
Anything
else? I mean,
it
really starts with the basics of housing and support. Yeah. The continuity of care is a massive issue that the clinicians are handed somebody out of the inpatient unit, and then they don't have a relationship with them. They don't have the kind of ability to do the kind of work with somebody where they would, if we're going to keep CTOs, where they would see that they wouldn't need a CTO with them. They don't have the trust. the people don't have the relationships, the support, the access to work, the access to community, the access to transport. All these really basic things are essential to, if we're going to keep CTOs, to reducing the excuses that people use as reasons that people need to be on CTOs. Even things like getting Meals on Wheels and home and community care, and these, you know, super basic things. We could happily drop CTO use by 80%, I think, by meeting those social determinants.
Yeah.
Thank you, Chris. Sudeep?
I'll probably just quickly add, so as some of you might know, we at the Alfred, we launched the reducing restrictive interventions approach about 2 or 3 years ago to reduce the seclusion and restraint use in the inpatient unit, and we've been quite successful in that regard. So there's still work to be done. I think you can never stop working in these sort of spaces because it needs that ongoing commitment. But more recently, we've been thinking about sort of broadening the scope and looking at all compulsory orders as a way, you know, is something that we need to go into next, while keeping on, you know, the work with the seclusion and restraint part of it. Early stages, we haven't really, you know, we haven't got there yet. We haven't really even started the process in a big sort of way. But I think I think it's a natural progression from our perspective. And the reason why we look at it like a project is when you look at why something is happening, there are a multitude of factors that underpin that behavior. You know, when we looked at seclusion and restraint, you know, we had to find a way of taking the workforce along so that they own that process. Otherwise, if you stop looking at what's happening there, those practices creep up again. So this had to be something that the workforce on the floor owned and said, we are doing this. It took a while. There was a lot of leadership from inpatient staff that had to go into actually making that happen. And that's what has resulted in it being sustained. So now people never think of what we call the cyborg call, you know, when it's an early intervention call when somebody is displaying behaviors that are concerning. We go there, we find out what's going on, and we try and support the person the best we can. And perhaps a similar sort of project approach to looking at compulsory status is where we are going next.
Helen, can I just quickly say three things that I reckon would really help also. One is going back to that idea of having a plan to get off orders. I think that should be the way that's just routine practice. Because it's just it's such a hopeless thing to not have an idea of when you can resume your own decision makings and exactly how that's if you are on orders. The other thing is peer-led initiatives. So everything from the range of peer-led alternatives that are kind of respite based or, you know, housing to peer support that's, you know, around voice hearing approaches or, you know, those kinds of just a plethora of alternative non-coercive approaches. And the third thing is really wanting to, what can we do to ensure that this is a world that is enlarged in its sense of the kind of magical and diverse ways people make sense of life and the way that they live their lives, and have a much, much bigger, more open sense of that rather than a fear-based idea about connecting with people and, you know, who people are.
Thank you, Cath. I think that's a good note for us to actually, finish off in terms of with the panel, a focus on, the things we might be able to do. And there's so much more we could talk about. Just before I hand over to Louise to close the event, I just want to thank Cath, Sudeep and Chris for taking the time to be with us today. They've all made contributions to IMHA, and I'm sure we'll continue to do so over the past 5 years. And also, I just want to quickly say, I want to thank the IMHA staff, both the past and present IMHA staff, and the Speaking from Experience members for their dedication and expertise. The service can stand with people subject to compulsory treatment or a risk of this because of the support they provide for them to be able to use their voice and have their lived experience expertise amplified. And, you know, that's the reason why we can do this work, because, you know, consumers let us into that part of their lives so that we can do that. So I really just want to acknowledge the staff and hand over to Louise to close the event.
Thanks very much, Helen. My video's been stopped by the host, so now they've asked me to start my video. Very instructive.
Sorry.
But look, I too just wanted to, in closing, thank Cath and Chris and Sudeep. That was a fantastic discussion, I thought. I'm both a lawyer and a social worker. I was a social worker long before I was a lawyer. So it's terrific to get, you know, user experiences, clinical experiences, social workers and professional experiences, and the legal stuff sort of surrounding it. Really fabulous. And thank you for your honesty and for tackling the difficult ones. And thank you too for your very good wishes for the 5th birthday of IMHA. I wanted to particularly thank, in closing, IMHA staff. I think none of this would happen without IMHA staff, and for their listening, but for hearing when they listen. I think that's a really important piece. Their hearing of people's voices and their promotion of consumer rights is really at the core of it. I too want to thank VLA staff, and many of our VLA staff who are involved in this work, led by Rowan McRae, who leads our Access and Equity and Civil Rights area. It's a terrific directorate in legal aid, and very potent, and does lots of good work from IMHA to RoboDebt and all those other sorts of areas. So thank you very much to VLA staff. And for the work that both IMHA staff and VLA staff have done on our contributions to the Mental Health Royal Commission. And like me, I'm sure you're all looking forward quite anxiously to what the findings and the recommendations of the Commission will be early next year. And finally, I'd like to thank Helen for her chairing of the panel, but just also her tireless work across legal aid in relation to this, and to note that IMHA's work has had influence in other areas of Victoria Legal Aid's activity, and we have seen that in some child protection areas, and just more generally in this idea of putting users at the centre of what we do, which is very much captured in our client first strategy, and which all VLA staff are required really to keep at the centre of their thinking for the work that we do. So thank you very much to everybody for all your time and effort. Happy birthday to IMHA, and thank you too for everyone for all your work on the Your Story, Your Say pieces, which I agree are well worth the read. Take care, and we'll see you, well, whichever next anniversary it is, we'll see you then. Thank you.